Another very important structure in terms of its clinical significance at the level of the palm or the ventral aspect of the wrist is the carpal tunnel, because it is commonly involved in a clinical condition known as carpal tunnel syndrome, and which leads to the symptoms of numbness, paresthesia, etc. in the hand, as well as weakness. So that's what we're going to talk about in this series of lecture, which is the anatomical structure called as the carpal tunnel, because it is of great significance clinically, as I already mentioned. So in this lecture, we're going to talk about the structure of the carpal tunnel, the contents of the carpal tunnel, as well as the flexor retinaculum and the palmar aponeurosis. So what is carpal tunnel? So carpal tunnel is actually a tunnel. It's an anatomical tunnel through which different structures pass, and is formed anteriorly or ventrally at the level of the wrist by a deep arch formed by the carpal bones and covered by the flexor retinaculum, as you can see in this picture. So there are bones beneath, which are the carpal bones, and then there is the flexor retinaculum above it, and there are different nerves, arteries, and musculotendinous structure passing through it. So based on what I just said, we can predict the roof and the floor of the carpal tunnel. So the roof is formed by the carpal arc. The floor is formed by the carpal arc, and the roof is formed by the flexor retinaculum, and the structures such as the musculotendinous structures, nerves, and vascular structures pass through it, or you can say above the carpal arch and beneath the flexor retinaculum. So the base of the carpal arch, or you can say the floor of the carpal arch, is formed medially by the pisiform bone and the hook of the hamate, and laterally by the tubercles of scaphoid and trapezium, as you can see here. So here we have the hamate, here we have the capitate, here we have the trapezoid, and here we have the trapezium, and this carpal arch is actually making the base or the floor of the carpal tunnel, through which different structures such as the nerves and the muscle tendons pass, and it is actually covered on the top by the flexor retinaculum. So moving on, flexor retinaculum, as I already mentioned, forms the roof of the carpal tunnel, and it is a thick connective tissue ligament, or it is a thick connective tissue fascial or connective tissue structure, and it bridges the space between the medial and the lateral arch of the medial and the lateral sides of the carpal arc, or the base of the carpal arc, and it converts the carpal arc into a carpal tunnel through which different structures pass, as you can see in this picture here. So here we have the tendons which are passing through the carpal tunnel, and these are actually covered on the top by the flexor retinaculum. Now the flexor retinaculum holds the tendons to the bony plane at the wrist and prevents them from bowing, also known as the bowstring effect, in the case of the absence of the flexor retinaculum or the insufficiency of the flexor retinaculum. Now talking about the contents of the carpal tunnel, as already mentioned, it has muscles, nerves, and vascular structures as well. So it has 4 tendons of the flexor digitorium profundus and 4 tendons of the flexor digitorium superficialis. On one side, it also has the tendon of the flexor carpi radialis as well, and the tendon of the flexor pollicis longus. So these are present on the lateral side, the tendon of the flexor pollicis longus and the flexor carpi radialis, whereas the flexor tendons of the flexor digitorium profundus and the flexor digitorium superficialis is located on the medial side. In the center, we have the median nerve, and that is why that in the case of the carpal tunnel syndrome, in which this facial structure or the facial sheath, which is known as flexor retinaculum, compresses these structures beneath, which is located beneath it, in terms of the carpal tunnel structures which are passing through it. They are actually compressed in this tunnel between the carpal bones and the flexor retinaculum. The median nerve is one of those structures, and that is why it gives a sense of pain, paresthesia, or numbness, or other neurological symptoms in its distribution, which is lateral 3.5 fingers. So as we were talking about the contents of the carpal tunnel, we can also observe these carpal tunnels in this magnetic resonance image scan of the at the level of the wrist. And here we can see that we have the flexor carpal radialis tendon. We also have the flexor pollicis longus tendon. We also have the median nerve here, and here we have the tendons of the flexor digitorium superficialis, and here we have the tendons of the flexor digitorium profundus, and above them we have the flexor retinaculum, and here we have the bones, which is the trapezium, trapezoid, capitate, and hamate. So these are actually the bones, these are the tendons, this is the nerve, and these are the tendons on the medial side, and these are the tendons on the lateral side. So as these muscles are passing, or these tendons are passing beneath the flexor retinaculum, and they are direct in contact with the bones, which is the carpal arc. So they are actually involved in a lot of movement in close proximity to the bones, and thus there can be a lot of friction and thus wear and tear at the level of the tendons. And for that reason, to offer them protection, there is actually the formation of the synovial sheath at the periphery or around the circumference of the tendon, so to allow free movement of the tendons in the carpal tunnel, which is facilitated by the synovial sheath, and they surround the tendons. So as we can see here, so we can also see the contents of the structures here. We were talking about the flexor pollicis longus, the flexor digitorium superficialis, and the flexor digitorium profundus. Here we also have the flexor carpal radialis. It is not exactly beneath the flexor retinaculum, but on the you can say it is surrounded by the vicinity of the flexor retinaculum, and the involvement of the flexor retinaculum can actually involve this muscle in cases as well. But we can see that the median nerve is present beneath the flexor retinaculum, so whenever there is actually a compression of the median nerve because of the increased compression in the carpal tunnel, so there would be symptoms or neurological symptoms in the lateral 3.5 fingers. But the medial 1.5 finger is spared of the symptoms because of the fact that it is supplied by the ulnar nerve on the ventral or the palmar aspect, and that is outside the flexor retinaculum, and thus that is why its symptoms are not observable. Now, talking about the contents anterior to the flexor retinaculum, as I already mentioned, we have the ulnar artery, the ulnar nerve, and the tendons of the palmaris longus muscle, which pass into the hand anterior to the flexor retinaculum. So these structures are not involved when we talk about the compression of the structures in the under the flexor retinaculum or in the carpal tunnel. So as I already mentioned, the ulnar nerve is spared, and thus the lateral 1.5 finger is spared from the symptoms of the neurological source, and because the median nerve is compressed and ulnar nerve is spared. So they do not pass through the carpal tunnel, so the carpal tunnel syndrome, which is a clinical condition, will not have the symptoms of these structures. And the tendon of the palmaris longus is not surrounded by the synovial sheath because it is not in direct contact with the carpal bones, and it is located outside the carpal tunnel above the flexor retinaculum. Another important structure is the palmar aponeurosis. It is actually a thickened form of fascia, also known as palmar fascia as well, and it is in the aponeurosis of the palm or the ventral aspect of the hand, and it consists of two layers. One is the superficial longitudinal layer and one is the deep transverse layer, and the superficial longitudinal layer is continuous with the tendon of the palmaris longus, and that is why it is also said that it also serves as an insertional or attachment site for the palmaris longus, through which it exerts its function. So that is all about the carpal tunnel and the clinical significance of the carpal tunnel, its contents and structure, and as well as the palmaris, palmar fascia or the palmar aponeurosis, which also serves as an attachment site for palmaris longus. And I hope you learned something new out of it. Keep on watching sqadia.com for more lectures like this. Thank you very much.